Welcome to this Step 2 clinical knowledge review on headache test-taking strategies. This video is designed to help you recognize common question patterns and apply clinical reasoning efficiently on exam day. Remember, the goal is not to memorize every detail, but to recognize the patterns that board examiners love to test. Before we dive in, make sure you have reviewed the headache chapters in First Aid and your question bank. This video will focus on how to apply that knowledge when you see it on the exam. Here is what we will cover today. First, we will learn to recognize the high-yield question stems for headache on your board exam. Second, we will apply test-taking strategies to differentiate primary headaches like migraine, tension type, and cluster headache from dangerous secondary headaches. Third, we will master the next best step question format, which is where most students lose points. Remember to review First Aid, your question bank, and Pathoma for the foundational content. This video is about applying that knowledge strategically on exam day. This is your first and most important strategy. When you see a headache question, your brain should immediately sort it into primary versus secondary. Primary headaches have recurrent patterns and typical features. The stem will give you words like recurrent episodes, typical pattern, and known triggers. These point toward migraine, tension type, or cluster headache. On the other hand, secondary headaches have alarm features. Watch for worst headache of my life, thunderclap onset, new headache after age 50, fever with neck stiffness, or focal neurologic deficits. When you see these red flags, the answer almost always involves imaging or lumbar puncture, not just giving a pain medication. Now let us refine your pattern recognition for the three major primary headaches. For migraine, look for unilateral throbbing pain, photophobia, phonophobia, nausea, and visual aura. The pain is worsened by physical activity and lasts 4 to 72 hours. For tension-type headache, the buzzwords are bilateral, band-like pressure, mild to moderate severity, no nausea, and not worsened by routine activity. For cluster headache, look for a male patient with severe periorbital pain, ipsilateral lacrimation, and rhinorrhea, agitation with pacing, and episodes occurring at the same time daily in clusters lasting weeks. Each episode lasts 15 to 180 minutes. Let us look at the classic stem patterns you will encounter. For migraine, the stem will describe a young woman with throbbing unilateral headache, photophobia, nausea, and visual aura. She retreats to a dark room. For cluster headache, expect a male patient with severe periorbital pain, tearing and nasal congestion on the same side, who wakes from sleep at the same time nightly and is pacing or agitated. For medication overuse headache, the stem describes a patient taking over-the-counter analgesics daily with headaches that worsen despite increasing medication. Watch for the rebound pattern where pain returns as the medication wears off. Here is your first practice question. Read the stem carefully and try to identify the pattern before looking at the answer choices. This patient has recurrent episodes of severe, throbbing, unilateral headache with nausea, photophobia, and visual aura. The headaches are worsened by physical activity. This is a classic migraine presentation. Now look at the question. It asks for initial treatment for acute episodes. This is a critical distinction. Make sure you identify whether the question is asking about acute treatment or preventive therapy before selecting your answer. Let us walk through this answer together. In step 1, we spot the pattern. Unilateral, throbbing, nausea, photophobia, visual aura, worsened by activity, lasts hours. This is textbook migraine with aura. In step 2, we focus on what the question is actually asking. It says acute episodes, which means you need an abortive medication, not a preventive one. In step 3, we eliminate wrong answers. Propranolol, Topiramate, and Amitriptyline are all preventive medications used for migraine prophylaxis. None of them work for an acute attack. The correct answer is A, sumatriptan. Triptans are first line for acute migraine with moderate to severe symptoms. Always read the question stem carefully to determine if they want acute or preventive treatment. Here is your second practice question. Read the stem and identify the headache pattern. This patient has excruciating unilateral periorbital pain with ipsilateral autonomic features, including tearing and nasal congestion. He is agitated and pacing. The episodes recur nightly at the same time, and each lasts about 90 minutes. Take a moment to think about what headache type this represents and what the first-line acute treatment would be. Let us walk through this cluster headache question. The classic pattern is all here. Male patient, excruciating unilateral periorbital pain, autonomic features on the same side, agitation with pacing rather than lying still, recurring at the same time nightly, and each episode lasting 60 to 180 minutes. Now for the treatment. High-flow oxygen at 100% via non-rebreather mask is first line for acute cluster headache. It works within 15 minutes and has no significant side effects. Oral sumatriptan is too slow for cluster headache. Subcutaneous or intranasal triptans are acceptable alternatives, but the oral form is not. Ketorolac and ibuprofen will not adequately treat the severity of cluster headache pain. The answer is B, high-flow oxygen therapy. This slide covers the secondary headache red flags that board examiners love to test. You need to have these memorized. New-onset headache after age 50 could be giant cell arteritis or a mass lesion. Thunderclap onset reaching maximum intensity within seconds suggests subarachnoid hemorrhage until proven otherwise. Headache with fever and neck stiffness points to meningitis. Papilledema or focal neurologic deficits suggest a mass lesion or increased intracranial pressure. Positional headaches suggest intracranial hypertension or a colloid cyst. Progressive headaches that change in character warrant further investigation. When the exam presents red flags, the answer is almost always imaging or lumbar puncture. Thunderclap headache gets a non-contrast computed tomography head first. If negative, lumbar puncture follows to rule out subarachnoid hemorrhage. Do not be tricked into choosing empiric treatment when red flags are present. Here is your third practice question about medication overuse headache. Read the stem carefully. This patient has a known history of episodic migraine that is now transformed into daily headaches. She is taking a combination analgesic almost every day. The headaches briefly improve after taking the medication but return within hours. This is the classic rebound pattern. Think about what the most important next step would be. Let us walk through the medication overuse headache answer. The classic pattern is here. History of episodic migraine now transformed to daily headache, daily analgesic use exceeding 10 to 15 days per month, and temporary relief followed by rebound. This is medication overuse headache. The key distinction is that you cannot simply add a prophylactic medication on top of the overused analgesic and expect improvement. The most important step is withdrawing the offending medication. This should be done with a structured plan, often with a bridging medication like a short course of a steroid or a long-acting anti-inflammatory. Switching to a stronger analgesic like an opioid would make the problem worse. Imaging is not indicated because this is a clinical diagnosis. The answer is C, withdraw the overused medication with a transitional plan. Here is an important test-taking pearl about migraine prophylaxis. The board exam loves to ask when to start preventive therapy. The threshold to remember is 4 or more migraine days per month, significant disability despite acute treatment, or when acute treatments are contraindicated or being overused. First-line preventive agents include Propranolol, Topiramate, Amitriptyline, and Valproate. Also know that Triptans are contraindicated in patients with a history of cardiovascular disease, including coronary artery disease, uncontrolled hypertension, and prior stroke. If the exam gives you a migraine patient with heart disease, Triptans are wrong, and you should choose an alternative like an anti-inflammatory or consider preventive therapy. That wraps up our headache test-taking strategies for Step 2. To review, remember to always sort headaches into primary versus secondary first. Know the classic buzzwords for migraine, tension type, and cluster headache. Always check for red flags before choosing a primary headache diagnosis. And pay close attention to whether the question asks for acute or preventive treatment. For further study, review the headache and neurology chapters in First Aid and your question bank. Focus on the diagnostic criteria tables and the red flag features for secondary headaches. Visit roadmaptoresidency.com for expert tutors and residency advisors who can help guide your board preparation. Please like this video, subscribe to the channel, and share it with your classmates. Good luck on your exam.